Welcome, everyone, to Just in Case, What to Do if Congress Doesn't Extend the AHCAH Waiver in 2024, a webinar sponsored by the Hospital at Home Users Group, presented in partnership with the American Academy of Home Care Medicine and the American Hospital Association. We'd like to recognize the generous support of the John A. Hartford Foundation for the Users Group and for this webinar series. The Users Group is the nation's premier collaborative focused on acute care at home. The Users Group shares resources and best practices, works together to expand our program's reach, and informs regulatory reimbursement and payment policies necessary to build the field and spread this hopeful, person-centered model of care. Please visit our website and be sure to check out our TA Center for helpful hospital at home program resources and tools, including all of these webinars. There are 27. This will be our 28th in all. Find a topic you have been thinking about or working on, and please take a look. Finally, a team of researchers at Mount Sinai is looking to interview hospital at home caregivers for their input on the caregiver experience and a range of equity issues related to hospital home policy, practice, and research. We need your help to connect with caregivers, so please get involved and simply scan the QR code on this slide or contact us at info@hahusersgroup.org. It's now my pleasure to introduce our moderator for today's webinar, Dr. Linda DeCherry, a member of the Hospital at Home Users Group leadership team and a national expert on hospital at home programs. Dr. DeCherry is the Vice President for Clinical Strategy and Implementation at Medically Home, where every day she helps sites around the country implement hospital at home programs. Previously, she was at Mount Sinai Health System for almost 2 decades and was the clinical director of Mount Sinai at Home, its home-based service line. Please take it away, Linda.
Thank you so much, John. And I'm excited for this very much pertinent webinar. We've titled it Just in Case, What to Do if Congress Doesn't Extend the AHCAH Waiver in the next couple weeks. So I'm going to start with some introductions here of our speakers. Then I'm going to give a little bit of an intro, and then we're going to turn it over to our 2 speakers. And we have plenty of time for questions, so please start thinking about them. I know everyone has a lot of questions, so you can start thinking about those now and putting them in. So our first speaker today is going to be Dr. Elizabeth DiPiero. She is the Medical Director of Presbyterian Complete Care, Hospital at Home, and Post-Acute Care at Presbyterian Healthcare Services in New Mexico. Dr. DiPiero has been working in providing home-based medical care since she joined the organization in 2010. Her passion for home-based medicine started when she had an opportunity to work in the Elder House Call program with Dr. Bruce Leff during her residency. Presbyterian's hospital at home program started in 2008 and has served under the home health care license, serving Presbyterian insurance patients, and grew to include Medicare beneficiaries during the pandemic. Dr. DiPiero's team continues to work on expansion of these programs to help provide care to New Mexicans. Our second speaker is going to be Dr. Lindsay Williams. She is the director of Cedars-Sinai at Home in California, where she leads innovative initiatives to provide high-quality, patient-centered care in the home setting. With extensive experience in nursing, project management, and healthcare leadership, Lindsay excels in developing and implementing advanced care models that improve access and outcomes for vulnerable population. In her dual role as both nursing director and administrative director, she has successfully integrated clinical and operational excellence, driving program growth and scalability. Lindsay is passionate about advancing virtual care, building collaborative teams, and shaping the future of remote patient monitoring and home healthcare delivery. So we're going to hear from both of them in 1 minute. I'm just going to do a brief update of what I know today of the waiver. Oh, panel disclosure is very important. They have none. So update on the waiver, and this is evolving. I've been in meetings the last couple hours. There might have been something new that I'm not aware of. But what I do know is that earlier this week, The 5-year extension was written into the continuing resolution after extensive negotiations for the last couple of weeks, back and forth with Republicans and Democrats, and it seemed on track for voting this week. Yesterday, that seemed to have been derailed. Was not derailed because of hospital at home concern about this particular waiver. It was the derailment was because there's just a lot of things in that continuing resolution bill. And both sides are still kind of working that out. So we have that as one possibility of a potential 5-year if that continuing resolution gets brought for a vote in the House and the Senate. Doesn't look as likely. And then we have a possibility of just what is called a kick the can extension for maybe about 3 months of continuing everything that's right today and let the next administration, the next Congress, make a decision on a more long term. So that's where we're at today. These things are complicated and evolving, but without something, as it stands, the current waiver ends on the 31st. I do want to remind everyone that 2 years ago, the extension came through on the 29th. So these things do happen very last minute, but that's where we are right now. There is definite uncertainty as to when this will happen and in what format. So that is exactly why we have our webinar today. We have 2 programs that have had experience in operating not under the waiver constructs, and we're going to have them explain how they did that, what are some of the considerations related to that, and then we'll have a discussion both on how they operate and what are you going to do on the 31st when you have a census of, let's say, 10 patients, what are you doing on that day? So I'm going to turn it over to Dr. DePiero to have her do her presentation.
Okay, thank you, Dr. Ducheri. Thank you for having me. I appreciate the opportunity to discuss this with all of you. I work with Hospital at Home under Presbyterian Health System in Albuquerque, New Mexico. So the next few slides will kind of give you an overview of what we've done in the past. We've gone through like 3 iterations of how we ran our program. This slide just has some general information. I think that the main point is the first one here, which is what allowed us to start our program in 2008 and function without Medicare approval, essentially. We are an integrated health system so that we have a delivery system, a medical group, and most importantly, Presbyterian Health Plan. At that time, there was a terrific bed shortage in New Mexico, as there is again now. And there was a lot of pressure and a lot of drive to try to find alternatives to care for these patients to free up hospital beds for folks who were sicker and really needed to be in the brick and mortar. So we work with our health plan, and they approved moving forward with Hospital at Home. So we opened in 2008, and at that time we opened as an outpatient department, and we're able to take only Presbyterian insured patients, since that was the only insurance that was basically contracted with us. In September of 2021, once the CMS waiver was out, we switched to functioning under the waiver for everything, Medicare patients as well as our Presbyterian patients. So at that time, we changed our program to be an inpatient program under Presbyterian Hospital, created a virtual hospital essentially for documentation and orders, and went forward with the waiver. Since our inception in 2008, we've cared for about 2,120 patients. That was through the end of November of this year. Since we started functioning under the waiver, that was in September of 2021. It took us about a year to get our virtual hospital set up and going in Epic. So under the waiver, we've cared for 661 patients. Of note for us, 33% of those have been Medicare patients that are not Presbyterian insured. So still the bulk of our admissions are carry Presbyterian insurance. I'll say now that we do have several expansion plans in place and that we're developing. And as part of that, we are hoping to access Medicare populations at some of the other hospitals in our city. Obviously, that will depend on the situation with the waiver. Past 6 months, we probably had 25 to 26 admissions per month. So we opened in October of 2008, and the way we functioned for the next 6 years is what's described below. Basically, as far as the electronic medical record, at that time, we were using McKesson Home Health. And the reason for that was that when we opened, we were functioning under our home health care license. Presbyterian has a home health care agency, and they still have that to this day. So it was sort of a logical place to open the program under that license. The difficulties there were that obviously we had to follow all home health rules and procedures, which included OASIS as part of documentation for the nurses. For those of you that are not familiar with OASIS, it can be quite cumbersome and time consuming, but at the time, that was what we used, and for the 6 subsequent years. As far as our pharmacy, and again, we were an outpatient program under the home healthcare license. Pharmacy-wise, we contracted with outpatient infusion pharmacies for our IV medications and IV supplies. And we used the outpatient pharmacy that we contracted with for oral meds and narcotics or anything really that was oral. We had initially tried to use the hospital pharmacy, but that was extremely difficult because they're really not set up to dispense outpatient medications. So we quickly pivoted to this form of obtaining our medications. As far as reporting, or in the original format, we used McKesson for data, Midas, and then manual spreadsheets. So as you might imagine, it was quite cumbersome and probably seems very old-fashioned now, but that's how we kept track of all our data for the first 6 years. Billing was, again, contracted through our health plan. We had manually created invoices that went to the health plan, and our agreement with our health plan was that they would pay us based on the DRG, the condition-based DRG, they would pay us a lump sum. So if we had somebody with CHF, we got a lump sum for the admission, whether they were with us for 4 days or 10 days, we got one basic amount, and we did not bill professional fees during that time. So our next sort of iteration of hospital at home was in 2015. By that time, all of Presbyterian had moved to Epic as their electronic health record system. We were the last unit of the whole Presbyterian system that went over to Epic, and that was very intentional because it was quite cumbersome to try to switch all our orders and the way we did things, since we were an outpatient program, over to Epic. At that time, we were using ambulatory Epic since we were outpatient. Legally, we were under our Presbyterian Medical Group. So basically, we were a provider supervised program to allow nursing to be in the home, etc. Pharmacy-wise, we didn't really need to make any changes with that. We continued with our contracted outpatient pharmacy for IV medications and our outpatient pharmacy for our oral medications. I will add that we did have other contracts also, for instance, for placement of midlines and PICC lines. We were contracted with an outside provider. We were contracted with an outside company for in-home X-rays, in-home EKGs, as well as Dopplers. And we had that also from the initial inception of hospital at home. At this time, as far as reporting, we continued with Midas, and so much of our data was already in that system, but we did start transitioning to Epic since it was a much, I guess, friendlier, user-friendly way to try to collect your data and track things and build lists and programs that you could follow. Once we were in Epic, billing became more customized in that we were using Epic to bill, but we had to build special codes that were predetermined based on the conditions and the DRGs associated with those conditions. And those bills went automatically to our health plan. And again, it was like before, we were getting paid a bulk sum for that condition. No professional fees were billed separately. The other thing I will add was that around that time, between probably 2013 and 2015, we did try to contract with other insurance providers. And we were in quite a few talks trying to see if we could work out contracts with them. This was before the waiver. But in the end, none of those panned out. None of those worked out. People were very cautious about, going into something like this before the Medicare waiver was in place. So then once the waiver was out there as an option, we again switched how we did our hospital at home. We continued with Epic, of course, as our electronic health record, but we switched to inpatient Epic. So our Epic group had to build us a virtual hospital. So we essentially became a unit of Presbyterian Hospital and we're functioning under the licensing of Presbyterian Hospital. But they had to build us a virtual hospital. I'm sure a lot of you went through this so that we could document in Epic, do all our orders, nursing documentation, et cetera, as a unit of the hospital. Some of the difficulties in that, being an inpatient unit of the hospital, was trying to get the other inpatient units as well as the emergency room to understand that and work with us effectively. But I think we've been doing pretty well over the last year and a half with that. Pharmacy-wise, once we became an inpatient unit, we switched back to an inpatient pharmacy for all our medications, IV medications as well as oral medications. Except for narcotics, the inpatient pharmacy could not dispense narcotics to us. So for patients who needed controlled substances, narcotics, or others, we retained a contract with one of the local outpatient pharmacies to dispense those for us. Reporting now has been, all our data is basically through Epic and reporting in Epic. And again, just like we've been doing since 2015, we are still billing through Epic with the DRGs to our health plan, but just billing normally to other Medicare providers. And those do include professional fees, as I'm sure most of you are aware of. So given the way we started, which was dealing with our health plan and only Presbyterian insured patients, if there's any delays or the waiver, if there's any problems with the waiver, we are going to continue to operate with Presbyterian insurance patients. I think our emergency plan right now, in case things don't work out as we would all like, is that as of December 27th, if we don't have there's not a firm plan in place for what's going on with the waiver, we will not be taking Medicare of other flavors other than Presbyterian after December 27th, just so that we don't have to, be dealing with transferring patients or things like that, just based on the fact that the waiver did not go through. So that's sort of our interim plan for right now, and hopefully we won't have to do that as we have a approved expansion plans for our program, all of that depending on the fact that Medicare would continue to participate with Hospital at Home, so we could start to reach out to other hospitals in the Albuquerque area for Medicare patients to offer this service. I will be happy to answer any questions at the end of this, but that's kind of our story.
Thank you so much, Dr. DePiero. I just want to clarify. So if there's a pause or a gap in the waiver, you're planning to go back to the Presbyterian Medical Group construct, that slide, basically, that kind of
at this point, that part I can't answer 100% for sure, because we're hoping that we will continue to function as an inpatient unit as an arrangement with our health plan. The difference would be we would only take Presbyterian insurance patients.
Understood.
Any
Okay, so you would
age,
stay in the
any
same
condition.
construct, but
Yeah,
one insurance.
exactly. Yeah, because it's easier for the rest of the system if we're in an inpatient unit. Yeah.
Very good. Great. Well, I know we're going to have a lot of questions about this going forward, but I think I'm going to let Dr. Williams speak now about the Cedars-Sinai experience.
Hi, everyone. Good afternoon. So yes, just kind of jumping right into it, presenting out on our program. So we call our program Cedars-Sinai at Home. We say it's our version of hospital at home because in the state of California, we have some regulations that I'll talk about shortly. But we have partnered with Medically Home, that's our vendor in this process, to launch our program. Our impetus, the genesis for this program came to alleviate the capacity challenges that we're having at our main medical center that's here in the West Hollywood, Beverly Hills area. Let me if I can turn my background off. Okay, that's better. And then we are also, building and leveraging long-term processes, structures. This is the first, which I'm sure not the last, entree into virtual care for us at Cedars-Sinai. Briefly, this is our command center team. So we have our physician, we have a dedicated pharmacist, care manager, command center nurse, and nurse practitioner that works in collaboration with our service provider network to provide services in the home. So our command center team, this is all Cedars-Sinai resources. And I'll talk a little bit more about this, but particularly our command center nurses and our pharmacists are inpatient resources that come from our kind of inpatient hospital space. And the physician, care manager, nurse practitioner, we have as part of our what we call ISP, inpatient specialty practice, it's our hospitalist group. So this program is kind of started and launched out of our main hospitalist group, kind of our Cedars-Sinai owned hospitalist group that serves about a quarter of our volume. We have 915 licensed beds, and so the ISP volume within that is about 250. So this program grew out of that, and so those resources come from ISP, and then our pharmacists and our command center nurses come from general medical center resources, and that'll could become important kind of in the next couple of slides here. So we launched on April 9th, earlier this year. We've enrolled about 170 patients, and that I think is actually just about to change today and become a little bit higher. We're closer to 175. So we have average monthly admissions of 21 to 22 admissions a month, and we're looking to grow our program. And so we are not a waiver program. We've never been a waiver program. We did apply and we received a waiver, but by the time we were set to launch, the public health emergency for COVID-19 had ended, and CDPH, the California Department of Public Health, decided that they did not have the regulatory authority to manage hospital at home programs. So it's saying you can't do it with us, but you can't, you could do what you want, but you can't do it as a full inpatient program that's licensed by CDPH. So to that end, for our program, we have a collaboration between Cedars-Sinai Medical Center, which is our inpatient hospital, and the system that aligns with that, and our Cedars-Sinai Medical Delivery Network. So that is basically our ambulatory arm. So our program is technically housed within the medical network with care provisioned under physician license. However, the care we provide is at an inpatient level. So at our senior executive leadership team, we are reporting out to our CEO of our medical delivery network, as well as our COO of our Cedars-Sinai Medical Center. And so we've had an agreement that, we're working in this way, but then in terms of the costs and how that works, we're basically charging eventually all of our cost center that happens within our Cedars-Sinai at home will pass through eventually to the medical network. So those resources that you saw that came from the inpatient space for our nurses and our pharmacists, we're charging those resources back to the medical network. Long story short. And so I'll talk a little bit more about what those differences look like with us working as a non-licensed program. So where this complexity really plays out for us in particular is with our pharmacy. So as we start to enroll patients, we have 3 potential pharmacies that we're using, right? Because we cannot use our inpatient pharmacy in our program. So we have our outpatient pharmacy, our Cedars-Sinai outpatient pharmacy that provides 5 days worth of meds when the patient is enrolled for the patient administered meds. And the patient receives those medications as when they are still in the hospital bed before they leave to go back to the home and enroll in our program. We also have an infusion pharmacy that we use for IV medications throughout the enrollment process, throughout the time the patient's enrolled in our program, starting with the enrollment all the way through. But then once the patient leaves the brick and mortar facility, our outpatient pharmacy can no longer provide medications to that patient once they have left the hospital. And that's due to regulatory things here for the state of California. So once the patient leaves the program, for refills, we use another long-term care pharmacy. And we use that process, to refill any other patient-administered meds, PO meds or otherwise, that the patient may need throughout the course of the program. The goal is that with that 5 days worth of medication, our typical length of stay is 4 to 5 days, that we would cover the majority of the meds that we would need. And 80% of the time that is the case. There's some times where we may need to refill or we're changing a dose and we're using our other pharmacy, but by and large, we are using our outpatient pharmacy to supply the bulk of the medications that the patient needs for enrollment. Something else that we do, and this is very specific to the state of California, we cannot use paramedics and they do not carry, and we cannot carry a formulary right now. So our outpatient pharmacy is also preparing what we call a PRN emergency kit. And that has things like hydralazine, famotidine, solumedrol, so things, Narcan, EpiPen, so things that might occur throughout the course of the patient's enrollment that they may need, right, in an emergent kind of situation. We are preparing that for every patient as they enroll in our program. And I know for some programs, you may have a formulary. Please check with your state, because I just went to a conference and I heard a lot of states are different as to what the outpatient pharmacy can do. But for the state of California and for our program, this is our method and our approach. So talking about our EHR build, and so this was the most amount of work for us because we use our inpatient workflows in Epic with some exceptions for our pharmacy enrollment and graduation order processes. We are using inpatient workflows, although we are technically an outpatient department in Epic. So we have a virtual care unit, our CS at Home unit. And if you were to look like you would just be looking at any hospital unit census, you would look and see us there. But for our process, the patient has to be technically discharged from the brick and mortar hospital and then enrolled into Cedars-Sinai at Home. So that is our process specifically. And so within that, there's a lot of different navigators that need to be built in our order sets in order to facilitate that change. So, and you can kind of see that highlighted here on the left. So we have a discharge readmit navigator that we built that has within that standard order sets for Cedars-Sinai at Home, as well as a MedRec. So our physicians have to go in and use this new discharge navigator, right, to discharge, and then they're putting in enrollment orders for Cedars-Sinai at Home, and then all of that goes to the pharmacist to verify all of the medication orders, and then that is what's deployed for the patient for their enrollment. We are also like the inpatient discharging physician. They're doing a discharge summary, and then we, as the Cedars-Sinai Home, we do an H&P. Right? So we're still doing all of those kinds of things that we would do in the inpatient space, but technically we have a discharge that is occurring in order to enroll the patient in our program. That is also the importance of having a dedicated pharmacist, right? Because all the little nuances that may come with transferring their inpatient prescriptions now to an outpatient space, right? We're looking at things like, if you have Q6 Zosyn or around-the-clock medications, we're changing those cadences. If you have around-the-clock IV fluids, right? We're changing those to boluses. So that's when we have our conversations about how can we tailor these prescriptions now to the home, but also from inpatient now to a outpatient technically unit. So with that, we have a whole host of things on our kind of internal website, and that's what you can kind of see on the right-hand side. So there's tools and training resources that we made for kind of every department that's involved. Another part of what we have to do to enroll the patient into our program Again, because we're no longer in our inpatient encounter, we have to create a new one. So we have to work with admissions, for example. So admissions has a part in this guide because they have a job aid for the new steps that they have to take. Imaging is another big one. So if we have to, because they're not in an inpatient encounter, if we have to bring the patient back to the medical center for a doctor's appointment, for a scheduled imaging, for a scheduled procedure, all of that requires us to hold the Cedars-Sinai encounter, basically put that on pause. We're talking about an LOA status, and I know Epic has kind of been in the development of an LOA status. We do not have that, and we're just working around it with our bed manager software in Epic. So we have to basically suspend the CS at home enrollment, and we schedule the appointment in that new department. And then once they're checked into that department, you know, they have all the things that happen in their encounter there. Then once they get back home, we put them back into the their Cedars-Sinai at home bed in Epic. So it takes a lot of manual steps, unfortunately. This is, like I said, this was the most significant part of building our program because we didn't have these tools before. So for our reporting and billing, so kind of internally, we have, we use Tableau to do our reporting for all of our kind of internal things, right? We're tracking bed days saved, we're tracking demographics, we're even tracking to, our 30-day readmit and return rates, but again, with some nuance because we're tracking 30-day, re-ED and readmit rates from the day they discharge from brick and mortar hospital, and then also from the day they graduate from our program, because like those kind of represent two separate things. And we also want to have an apples to apples comparison, to other data that may be happening. We have our safety incident reporting system that is housed within the medical network because we report to that system. So when we prepare, our data and our quality updates, we're sending that to the CMO of the medical network because that is the team, the quality team that we work with because that's where our program is housed. And as I mentioned before, we're reporting up to both medical center and medical network leadership. In terms of billing, we use and I should have said this before about our payers. We accept case rate payers. So for our situation, our DRG payments is basically what funds our program. So we accept, our Medi-Cal, Medicaid, our version of that. We accept our Medi-Cal kind of senior HMO plans, senior PPO plans. The only plans we really do not accept are commercial HMO and PPO plans, those that have a daily rate, for hospital stays. So those case rate payers are the payers that we accept for our patients. And so we do professional billing for our physician visits. So right when they're doing their daily visits, when they drop their H&P, when they do their discharge, we are dropping bills for that. But otherwise, we are not billing the patient's insurance because the 2 midnights they spend in the hospital to trigger that case rate payment is what basically is funding the rest of our program. And then for our service provider network costs, the service provider network vendors, they bill Medically Home and then Medically Home invoices us. So that's how we can pay for all of our services in our program. So kind of long story short, in us operating without a waiver, some good news and some bad news, right? So the good news is you have some flexibility, right? In terms of your frequency and timing of visits. There are some times if we're kind of stretched operationally, we may say, does this patient need 2 visits today? Right? Could the NP visit be 1 visit and then a second visit with our service provider network nurse? Or can they get 1 visit a day? Sometimes our patients want that. They're like, oh, it's too many people in the house. I want to go to sleep, right? We have that big flexibility to say, okay, we can use 1 visit a day. We don't have to have 2 nursing visits. The use of our FTEs, we can use folks very flexibly, right? In terms of who is doing what with our care managers, our resources, we can be very flexible as to how we use those folks. If we wanted to bring in LVNs, right, we have that flexibility. When we're also exploring temporary residence options for our network. I know within the waiver, there's some legal considerations as to what's considered a residence. We don't necessarily have those limitations there, right? So what we consider a residence is really as broad as what we want to apply as an organization. The bad news with that, there comes operational redundancy and potential for waste. For example, you saw that we use 3 pharmacies. That is a logistical hurdle that we have to overcome, right? When we're planning couriers, when we're planning care, which pharmacy is it coming from? Did the order transmit correctly? We ordered it as we ordered it constituted. It came unconstituted. Troubleshooting all of that now with 3 different pharmacies in itself is a challenge. The new bill that comes with the EHR, and then sometimes some manual steps that are involved, right? And that work that has to come with that. So, but you may be doing that anyway, right? If you had a waiver or not, just depending on your organization. So that's been the way we have launched so far. And that's it for me.
Thank you so much, Dr. Williams. That was some great information about your program. So we are going to open up the Q&A portion, and we have about 20 minutes or so for questions. There's some that are coming in, so please post them in the Q&A section. I'm going to start with a few that I have of my own, and then we're going to go into the audience questions. So I'm going to start with Dr. DePiero. So we heard what your program is most likely planning, which is to continue with to not take any more other patients except your plan on the 27th, if there's no extension of the waiver, and then continue only with that one insurance that you have a negotiated rate. What else had you considered, or your health system considered in that discussion?
So we had considered approaching the other providers in the state, United, Blue Cross Blue Shield, whatever, Cigna, to see if they would be interested in, opening talks to contract with us for hospital at home, because obviously we only take Medicare patients in those insurances, not the younger populations, right? And so we were thinking about starting those talks again to see if they would be interested in pursuing that. As Lindsay said, there's a lot of state-to-state variability. For instance, Cigna, in this state, we can't even take Cigna Medicare patients. They won't play at all, and the other thing we're going to do, obviously, is we can take PHP Medicaid, but the state is very open to letting us take Medicaid from the other 2 big providers that provide Medicaid services in New Mexico. So we have quite a few options, to continue with our expansion as planned, even if the Medicare waiver does not go through. I think the big hurdle there is going to be, if there's a problem with the waiver, there's probably going to be some less enthusiasm by insurance companies to participate. They all wait for Medicare to take the dive and feel comfortable. So I think that would remain an obstacle, perhaps.
Yeah. And the reason why we invited Dr. Williams here to present, not only is she a fabulous speaker, but to talk about a program, because they are taking Medicare, other patients, but they are staying a couple nights in the brick and mortar and then being discharged and being brought into this outpatient construct program, which is providing the same kind of high level care and finishing that time that they might have otherwise been in the brick and mortar hospital under this program. I hope I'm saying that accurately. And so, and you really are taking quite a wide breadth of insurances, but you did raise some of the challenges. So if a program today is an inpatient entity, to do what you're doing, they would have to either be hospital outpatient or be a physician practice to be able to do that shift. And then you illustrated the other things with pharmacy. So I think those are some of the potential, not a lawyer, check with your own legal team, but options that programs might have out there. All right, so we have a lot of questions. I'm going to start with some of those here. Oop, and they just went away. There we go. All right, so we started with, are there any plans to extend the waiver as standalone legislation the CR fails to pass? I think all options are on the table. I'm not sure if Dr. DePiero or Williams, you have any update on that aspect about other plans for legislative action.
Unfortunately, not. I don't.
Yeah.
It happens so fast.
No,
unfortunately.
Yeah. Here are some questions. I think there's some of these as kind of clarifying questions because everyone gave a lot of great information. So, what licensure is Cedars using for their program? Is it home health also?
No, because we're not, yeah, we're specifically say we're not a home health program. So our care is provisioned under a physician license,
Yeah.
and then we're housed as an entity within the medical network.
Yeah. How do you get the, this is also to you, Lindsay, how do you get the health plans okay with you shortening the brick and mortar stay to 2 days and completing the stay as an outpatient?
We have not done any real payer negotiations. And that's why we don't accept commercial payers, right? So the 2 midnights is kind of what triggers that DRG. And so I don't know if they're okay with it because we haven't done any negotiations, right? We're shortening the length of stay, right? So that is what we use as a driver, and we have bed days saved, right? So for every patient that we're enrolling in the program and taking out, that's now a new bed that we can fill as an organization, right? So, and then you can put, a more acute person in that bed, right? So you can do all the math there as to, what that means. But overall, for our organization, it's preferential.
We have some potential late breaking news. Someone has posted that a 90-day, 3-month hospital extension was circulated. So that might mean that folks might be voting on that soon. That's more positive than no extension. I think we all wanted the 5-year, but that's great news if that comes through. All right, so another person asked, is there a limitation to what insurances you can accept without the waiver? Or what insurances can you accept? I think that kind of would go to both of you. You've mentioned pieces of this, but maybe Liz, Dr. Shapiro, you can mention first, like you're going to go out to other insurances. Is there a limitation to who you can talk to?
No, I mean, I think, New Mexico is sort of a little different in that it's, we have the distinction of being the poorest state in the country. It also, as I'm sure a lot of you are aware, has probably the worst medical malpractice environment in the country. The legislature is not very friendly towards medical requests. So it's sort of an interesting political environment in that regard. Presbyterian Health Plan would continue to work with us, and we can try to work with whatever other payers we are interested in approaching and having a contract with. But as far as help from the state, I think Medicaid might be something that they would be willing to open wide. So Blue Cross Blue Shield Medicaid or the university plan, there's only 3 providers in the state that split the Medicaid population, and 49% of our population is covered under Medicaid. So it is actually, a large chunk. And I think the state is probably going to be interested in opening all of the Medicaid payers to hospital at home. So that's probably would be what we would pursue first, just because of the numbers.
And you're not taking them today, as you haven't had that
No,
opportunity.
we take Presbyterian Medicaid because that's always been understood. But no, we would have to go through the legislature to open it up to all of the Medicaid recipients in the state.
Dr. Williams, would you consider doing any other negotiations with those commercial payers that you're not taking today? Is there anything?
We would love to.
Yeah.
We had some preliminary conversations, but because we have just started, we don't necessarily have the volume and the heft, just yet. But we would love to have agreements so we can accept more commercial payers. Yeah, but for now, we take basically all, Medi-Cal was for us, Medi-Cal managed care, senior HMO, senior PPO. The only thing we really don't accept is our just commercial HMO and PPO plans. For us, it does help with equity, right? For programs such as this, folks who, may have, and we do accept uninsured, right? Because we can, kind of work on provisional care, provisional Medi-Cal. We do have that ability. So we can accept uninsured patients as well. So yeah, we have a little bit of flexibility there because, we can work on getting them some kind of provisional kind of plan while they're, in the hospital with us. And
Right.
I see a question that just came in. We technically, we call ourselves an outpatient program, but we do inpatient level care. So that's what we specifically have to say. So that's why we say Cedars-Sinai at home. We don't say hospital at home. We say Cedars-Sinai at home, and we are an outpatient program, but we do inpatient level care, and we are not home health. So that is a lot of the spiel and education that we have to do within our system so people understand our scope.
So we hope that this is, if there is a pause, it's going to be a temporary pause. What could folks do kind of quickly who may not have any insurance plans already negotiated, like you have the advantage of, Dr. DePiero, and are currently in an inpatient legal entity. You explained, Dr. Williams, you explained a lot of things that you did to make this a robust program. Is there a way to do this, that they could do kind of on a lesser basis to get it started, until we see the kind of full direction of this, especially for continuity of care for the patients who might be coming in like on the 28th, 29th, what would be possible?
That's a good question. I think it would be a couple of things, your regulatory and compliance folks and legal, number one, just making sure like that the care you're providing, so in terms of like the resources that you have, if you're already meeting those CMS standards, that is not likely to change. But what you can start to immediately change, right, is especially depending on your cost is a frequency. So again, I would be looking at how frequent are these folks going out, what's stated in the waiver, and then what can be maybe modified. So again, if you're doing two visits a day, we can do one. Right? And who's doing the visits? Again, for us in the state of California, it needs to be an RN, but does it have to be an RN in your state? Depending on the scope, I don't know, right? So those are kind of questions that you need to ask. I would also just be looking too at your pharmacy regulatory status, right? To kind of see immediately, if we kept these folks on, who would be the dispensing pharmacy? Because that is what could also change immediately if you don't have that inpatient status. Kind of your like quality reporting, a lot of that reporting status, that can maybe wait, but in terms of like immediate kind of operational things, I'll be thinking about staffing, I'll be thinking about pharmacy, and who's coming into the home, and then in terms of the tools that you are using in your system, right, for ordering, for the way that your orders may travel and stuff like that, and maybe putting together kind of like a quick build. Right. And because we've kind of condensed, we don't do like the full order set, right? We just have kind of like very quick, straightforward, streamlined order set, building that quickly so that you have kind of documentation to one, discharge, and then two, enroll into your program.
It would be discharging the patients on the 31st.
Exactly.
If you have the right construct for the rest, and then doing
and then enrolling them also on the 31st into whatever this version of your program is. So if you have your ambulatory network, your outpatient, if you have like a home, that's all the kind of partnerships. If you don't already have those, I would be looking to do immediately, right, to see where else you could house this program as an outpatient program. Do you have a community health worker program, people who already may be going into the home, community outreach, those kinds of departments to see where this could be housed. You already have the operational framework. You just need to kind of legal agreement there, or whatever kind of agreements you need to, house it under an outpatient ambulatory department.
We have two other questions here. So the one question is, could you confirm that on 12/31, can a program no longer accept new patients on that day and still take care of existing patients on service? Or is 12/31, would a program have to discharge or move back to brick and mortar all patients under service under the waiver? I don't know if Dr. DePiero, you're able to.
Yeah, and I think that's a legal question. Like our compliance department was kind of funny, actually. They somehow got wind of this, and they already reached out to us all in a panic about what are you going to do with the patients on December 31st, and their view was that as of, after midnight on December 31st, we cannot have any Medicare patients on service who are not Presbyterian insurance. And what their expectation was that if you do, those people get transferred to the brick and mortar on the 31st. and our PHP patients, Presbyterian, can stay with us, but everybody else. And that was from our compliance department. We
Yeah.
told them they were jumping the gun a little bit. We were a little bit more optimistic than they were, but yeah.
Yeah. And that's what I understand as well, even though that you
Mm-hmm.
say that might be the conservative. I think that is what we understand, is that you
Yeah.
cannot be a hospital in your home on the 1st. So everyone needs to be back if
Mm-hmm.
they are still in the admitted status. I know that CMS has guidance on their website, so please, everyone should go there and look it again. As you may not have looked at it for a while since you actually did your first waiver application. Go back and see, what they have for that. And then I think we have one more question that I see here about, and maybe this is for Dr. DePiero, because it sounds like you might be slightly smaller program if you're taking only one insurance. And the question is, are you going to be doing anything different with some of your staff during this time? Or are you going to play kind of a wait and see approach?
No, we were recently approved for an expansion, meaning, more positions, more nurses, with a plan to sort of form pods in different parts of the city and maybe eventually go into some of the closer rural areas. And I think we're going to continue that. And that's what I mentioned. We would probably go after getting the Medicaid approval for all of the state Medicaid populations, because we are a state where 49% of the people are covered by Medicaid. So that would actually allow us to not only maintain numbers, but expand beyond our current population. As far as staff, we have always had shared staffing with a couple of our other home-based programs. So we would not be losing anybody. We might reposition and expand our chronic disease management program, to reposition staff in that way. But we have a chronic disease management program, which is house calls based, providers, nurses, triage, couriers, labs, etc. And then we have a post-acute care program where we follow recently hospitalized patients who are not part of our chronic disease management. So we have home-based programs where we can put our already existing staff.
Yep. So there's
if it becomes
flexibility there.
necessary. Yeah.
Great. Great. Well, thank you so much to our panelists for your presentations today. I hope that for the audience, this was helpful to see some options. We don't know what's going to happen. We're all going to have our fingers crossed that this is extended, but we wanted to provide an opportunity to hear about how some programs operate who are not under the waiver or weren't under the waiver in the past. So I am going to hand this over to John Bielenson to close us out.
Thank you, Linda, and Dr. Williams, Dr. DePiero for really interesting and timely presentations on hospital at home and its prospects in the very near future. Hopefully, I trust it was productive and helpful for everyone involved. Would like to just to remind folks about the users group caregiver experience study. As I noted earlier in the webinar, we are trying to interview hospital at home caregivers to learn about their experience in a range of equity challenges related to practice, research, and policy in hospital at home. You can reach us at info@AHCAH if you would like to participate. Again, our webinar series is available on the hospitalathomeusersgroup.org site on the events page. There are 28 in all. I'm not sure what your web viewing is like, but you're free to binge all of these at once, or just find a topic that is of particular interest and to see the slides and or look at the webinar if you'd like. And again, the reminder that there is a wealth of information at HAHusersgroup.org, the Hospital at Home Users Group website. And we encourage folks to take a look at the Users Group Technical Assistance Center at the website there. With their featured resources, a webinar that we did recently on the CMS report on hospital at home. And we'd encourage folks to take a look at that as well. And finally, one last slide. We just want to thank everyone once again for your time and attention today, and also want to thank both the John A. Hartford Foundation for its ongoing support of the Users Group, as well as our partner, the American Academy of Home Care Medicine. Thank you, and we will see you next time.